Welcome again to another episode of the AOT Pod, an all-new FRCS-themed podcast, tackling key themes, challenging topics, and insightful intellect within otolaryngology. Hosted by myself, Josh Michaels, and Georgie Wellstead, with the support from the ENT UK Foundation and the Association for Otolaryngologists in Training. Today's theme is Hereditary Haemorrhagic Telangiectasia, and I'm pleased and privileged to be joined by Mr. Vikas Acharya, consultant rhinologist, facial plastics and ENT surgeon at the Royal National ENT and Eastman Dental Hospitals within UCLH. Vikas is a past president of the British Rhinological Society Juniors Committee and completed the highly esteemed post-CCT fellowship in advanced rhinology and facial plastics at UCLH under Mr. Prem Wendara and Professor Peter Andrews. So, welcome, Vikas. How are you?
Oh, I'm doing well, thank you. And thank you so much for the privilege to join you, Josh. I'm really excited to be with you and thank you for the opportunity.
Oh, well, the pleasure is all ours. Let's kick things off with a couple of quick fire questions. So, of course, you having recently CCT'd will have taken the exam not too long ago. When did you take the exam, or what was going on in your life at the time of preparing for it?
Well, I did the Section 1 exam in January 2022, and the Section 2 Viva was that April 2022 as well. And just to note, our first daughter was born in August 2021. So I was about 5-6 months into being a new dad with new parents, and then sat down to open up the books and start preparing for FRCS. So it was tricky.
That is tricky, and some challenges come across when you're juggling all of these commitments. What was your best way to approaching studying when this was all going on for you?
It's really tricky, but you have to get the work-life balance and approach it as another big milestone in your life, much like any type of exam or any major life milestone, whether it's getting married, moving house, or having the first child. It's exciting and you have to run with a bit of the adrenaline. But it was just happened to be that I was taking the exam. Our first daughter was born. I was doing a busy rhinology job in Imperial College, which had a 60 to 90-minute commute because of traffic. So balancing your work time as well as home time is important because you need to have family time. You need to be able to communicate and commit with other people in your life and do other things. However, often we don't maximize the time we have during the working week. So I would say is if there's downtime during lists between cases or after clinic or when you have SPT or admin, rather than traveling home or doing something else, just really maximize the 8 to 5, 8 to 6, Monday to Friday to be able to do what you can. And if you're going to balance that with not working in the daytime, then have some dedicated time in the evening. And when it comes nearer to the exam, you really have to offset sacrificing some of your personal time, whether it's weekends or evenings, on a more regular basis. So Section 1 is a little bit more tricky because it can be a bit lonely, that journey. But when it comes to the Viva, much like this, it's preparing to have a dialogue about a specialist topic.
I think that's great advice. And of course, you've gone through the exam, you've done your fellowship, you've now got a consultant post. Every hurdle comes with a bit of success and satisfaction at the end of it. What's your way of celebrating when you pass the exam?
Oh, so when we pass the exam, so what I thought is no matter, regardless of outcome, it would be nice to have a holiday booked for the week after the exam. So we booked a family holiday, the three of us, to go to Dubai. So I finished the exam and then 3 days later or something, we flew to Dubai for a week and it was nice. So I got the result, I think, either when I was there or just the day before I left or something. It comes quite quickly. And it was nice to have a holiday booked in advance as a way of thanking my family and have something to look forward to, some dedicated time together without having to open up the iPad or a book. So it was something to look forward to. And I would highly recommend that to all my friends and colleagues.
Absolutely. I'll try and get out to Dubai after the exam like you.
Yeah, somewhere.
Okay, so let's kick things off from a clinical perspective now. I'll present to you a case of a 44-year-old lady. She comes to your rhinology clinic after multiple hospital attendances with epistaxis, of which her most recent episode required admission for packing and coincided with the diagnosis of chronic anemia. So if you wouldn't mind, please proceed with an explanation of how you would assess this patient.
So, I mean, epistaxis is the most common ENT emergency that presents to the hospital, and over 60% of the population can have a nosebleed at some point in their life. And there's a myriad of underlying conditions that can contribute to its presentation. So, assuming that the patient's not currently bleeding or hemodynamically unstable or unwell, I would proceed by ascertaining the details of a most recent episode of epistaxis: onset, duration, laterality, severity, alongside any precipitating factors such as recent upper respiratory tract infection, previous sinonasal surgery or trauma, and any picking history or bleeding history or coagulopathy either with her or in the family. For example, when she goes to the dentist and has any treatment, is there excess bleeding, etc. I would also like to understand the frequency of these events, whether they were being more common or severe with time, and specifically whether hospital admission was required and what intervention was performed. I would also, because of my background in nosebleed disorder, be thinking about HHT. She's got recurrent epistaxis and needed to come to hospital with an anemia diagnosis. So in my mind, I'll be thinking about the epistaxis severity score in terms of frequency, severity, needing transfusion, diagnosis of anemia, whether she's needed iron, and whether she's needed any intervention such as packing. It might not be just epistaxis. There could be other sinonasal symptoms. So I would ask about anterior rhinorrhea, postnasal drip, anosmia, facial pain, nasal blockage, and if there's any laterality with that. Systemic symptoms are also important to ask about, just in general, about cardiovascular disease, chest pain, palpitations, and see if it was related to a cardiac or hypertensive event. It's important to talk about coagulopathies and liver diseases, but also to take a thorough drug history of whether they're on any antiplatelets, anticoagulants, and NOACs, etc. It's unlikely, but if they do have any known family or their own arteriovenous malformations, it's important to know about that. And a social and general family history will be helpful, and any bleeding disorders in the family. After taking that thorough history, I proceed to performing a full ENT and head and neck examination. That includes anterior rhinoscopy, and if safe to do so, flexible nasal endoscopy using a 3-pass technique. I'd look at the septum for any dilated blood vessels, septal perforation, telangiectasia, but also look for sinonasal disease such as mucopolyps, mucopus, and any evidence of generic rhinitis, and examine the postnasal space for any sinonasal mass, because what we must do is rule out a sinonasal malignancy with these kind of symptoms. If there's any active epistaxis, I'll make sure that I'm evaluating the state of the mucosa and making sure that I cauterize any dilated vessels if appropriate, and follow the BRS guidelines for the management of epistaxis, although HHT patients have a bit of a variation to these generic algorithms. If there isn't any epistaxis, I'll complete my examination by looking for global assessment of bruising elsewhere, including telangiectasia on the lips, tongue, mouth, face, and fingertips. I would also arrange for some other investigations after doing an examination, including a full blood count, advanced clotting profile, liver function test, renal profile, a baseline CRP, ESR, ANCA, ACE, and calcium are very helpful, as well as a vitamin D. And if there's any evidence of inflammatory processes such as nasal polyps, sinonasal masses, or destructive lesions, I would then perform a cross-sectional CT scan as required.
Brilliant. Thank you so much, Vikas. So the patient tells you that before moving to the local area, she was admitted to hospital on 3 separate occasions with epistaxis. She suffers with easy bruising and anemia, and this is familial with both her mother and grandmother suffering similar symptoms. At this point, what's your working diagnosis, and what would your management entail?
It's interesting because these fit at least 2 of the 4 Kurosawa criteria, and therefore raise the possibility of a diagnosis of hereditary hemorrhagic telangiectasia. We call it HHT, but in other places it's also known as Osler-Weber-Rendu or Weber-Osler-Rendu syndrome. The Kurosawa criteria is 4 criteria. 2 is probable diagnosis, 3 is a definite diagnosis. Now, what I would say is that this does commonly come up in the exam. People ask you, what's the Kurosawa criteria? So you can say it's a criteria for diagnosing HHT where 3 is definite and 2 is probable. It includes having evidence of, so I remember it by the name, hereditary, a first-degree relative with the condition, hemorrhagic, so evidence of oromucocutaneous or nasal bleeding, telangiectasia, evidence of telangiectasia either in the nose or oromucocutaneous region, and a central or visceral AVM, proven diagnostically on radiological imaging. So they're the 4, and 3 is definite and 2 is probable. With regards to the management of HHT-related epistaxis, this can be classified into conservative, medical, and surgical, and our approach is a bit different to non-HHT epistaxis. Nasal humidification, emollients, and making sure that the nose is lubricated, and avoiding trauma, particularly nasal picking, packing, etc., is crucial. Preventative therapies such as using rotational creams in the form of Naceptin, Mupirocin, also known as Bactroban and fusidic acid, is really helpful. We rotate those creams every 2 weeks so the nasal mucosa doesn't get used to the antibacterial properties, which is the whole purpose we rotate. But just remember that Vaseline serves a good function as well as aqueous creams to be able to keep it nice and lubricated. Neomed do a Sinogel, which is also quite helpful. Some patients like to use that. Nasal rinsing with Sterimar Baby or some saline drops is helpful. It helps prevent crusting and dry blood buildup, which can then fall off and, like a scab, then cause bleeding underneath. So rather than doing Neomed sinus rinse douching, which is high volume, high pressure rinse, using something that's a bit lower pressure is good for just removing those crusts. Patients should crucially have advice and guidance around managing anemia, particularly around low iron. So for that, a multidisciplinary team approach is excellent, using either a medical specialist in HHT, such as rheumatology, vascular, or respiratory, depending on which unit you work in. And the GPs are helpful at managing the anemia in the community as well. But iron is crucial for these patients to have, and you want a hemoglobin of around 10 to make sure they don't drop their iron, but some people have a lower vector, which is completely acceptable. Surgical treatments, I want everyone to think about, you do an interventional treatment to try and help improve their epistaxis severity score. So you don't just do something blindly because the patient has a symptom. If they're symptomatic with a bad epistaxis severity score, we want to do something to improve it, which is where something such as KTP or argon laser works. You do it because it's a 1 millimeter or smaller diode. It works finely in that area over the telangiectasia to absorb the same hematocrin wavelength of the red versus the KTP laser, and similarly the green argon works in a similar fashion. You want to reduce field trauma around the area. Why? Because if you use a bipolar cautery or coblation and you damage normal mucosa in HHT, this is a pro-angiogenic disease. It will just produce telangiectasia in the normal mucosa. So you're actually worsening their problems long term, which is what people fail to understand. We're doing everything to try and help improve the epistaxis severity score with minimal trauma. I usually offer a KTP laser 2 or 3 times a year. We would like to do it more often if possible, but you do them as you're able to book people in and based on their symptoms. So if they become symptomatic, it's good to call them in and do a laser. When that stops working, you can then move on to something such as a septodermoplasty, which is a skin graft we take from the thigh and debride the nasal septum mucosa to the perichondrium, attach it on. Some people glue, some people suture it, but what you need to do is make sure that the mucosal surface is facing out so that it sticks nicely and you get adherence to that area. And they last 5 to 10 years and you can laser on top of that until they stop working. Medical therapy such as topical and oral tranexamic acid is crucial. It's a game changer. And what that does is it helps them symptomatically at home, but also is preventative, particularly the oral tranexamic acid, to make sure that the symptoms don't worsen and become more severe in the interim periods. Oral tamoxifen have been used and topical estrogens in other practices. And we know about other anti-angiogenic medications such as doxycycline and bevacizumab, also known as Avastin, to be able to help. These anti-angiogenic or anti-VEGF medications really do help because it's a spasmodic disease problem in the tunica media where elastin's missing and they don't vasospasm. That's why they bleed so heavily. And what these things do is affect the endothelial lining, as you know, the VEGF component does. And we hope that by using small doses of these medications, they get longer term benefits. So surgical options vary. Laser's a good, excellent initial treatment. When that stops working, a skin graft called septodermoplasty. And eventually, if that stops working, then you can do a nasal closure, also known as a modified Young's procedure or a Lund's procedure, named after Valerie Lund, invented at the Royal National ENT. It's a 3-flap Mercedes-Benz type operation where you bring everything together and you're closing off the nose. Why does that work? If there's no air passing through the nose, it doesn't dry out the lining. You get atrophic rhinitis type picture where inside the nose you get atrophy and endothelialization, telangiectasia become inactive and stop bleeding. But mind you, it's important to know they do get 1 or 2 bleeds after having a closure, and it can take a month or 2 to start working. So that's the approach I would say to managing a patient with HHT for the FRCS. You've got the medical, the surgical components, and the surgical ladder in treating epistaxis. And if they're refractory to nasal closure, that's when stuff such as interventional radiology in an emergency situation can be helpful, and Avastin or bevacizumab, because we know it's a monoclonal antibody that's hard to get hold of. We usually use them for our refractory patients despite nasal closure.
That's wonderful. Thank you. So talk to us briefly about the pathophysiology of HHT and why it's relevant, please.
So HHT is an autosomal dominant inheritance pattern genetic disorder. It's got 5 different genetic types that exist. Over 80% of HHT cases are due to mutations in the ENG or ACVRL1 genes. Both of those code for receptors in the TGFB signaling pathway. For this reason, patients are at risk of both telangiectasias and anterior venous malformations, of which the lung, liver, brain should all be screened for. Usually in ENT, we do the lung, but our learned colleagues in other disciplines will help screen for the liver, the brain, spleen, etc. As such, these patients require an MDT approach for their care: ENT surgery, radiology, respiratory, hepatology, hematology, and genetic colleagues as well. A high-resolution CT scan of the chest and an ultrasound Doppler of the liver helps screen for lung and liver AVMs, and whilst the CT angiogram of the brain helps with cerebrovascular AVMs, the risk is quite low. It's 0.5% risk of stroke with this procedure, having an angiogram anyway. And is that more beneficial than looking for AVM which doesn't exist? So that's always balanced by our colleagues in an MDT fashion.
Fantastic. So we've touched on some of the MDT specialists that you like to work with and who provide some important aspects to their care. What are some of the broader considerations that need to be made when caring for patients with HHT?
Genetic screening is crucial for a number of reasons. Firstly, SMAD4 mutation predisposes patients to colonic polyposis, and so they need annual colonoscopy to make sure that they have biopsies to rule out a colorectal malignancy. Also, women of childbearing age with HHT are at higher risk in pregnancy of having symptoms, and therefore they should be referred for pre-implantation genetic screening and tailored fertility care if appropriate. And there are many centres around the country who specialise in fertility planning and family planning treatment for patients with genetic conditions such as HHT. Anemia and low ferritin are common findings, and therefore monitoring and treating them in the primary care is crucial, with low-dose iron or iron infusions if needed, because actually having an appropriate level of iron reduces the epistaxis severity score just as good as having TXA. It's really important to make sure that the iron's under control, and having a hematologist on board is helpful. Knowing their baseline hemoglobin when they're not bleeding so much is good. They often run lower than most of us, so we aim for a hemoglobin of 10 to make sure they're fit, healthy, and safe, but actually many of them have a hemoglobin of 70 to 80 and are pretty good. So it's just about working in MDT fashion to make sure that we don't over-transfuse them when it's not appropriate or needed. And because of the increased risk of septic emboli, many HHT patients get antibiotic prophylaxis. So whenever I do a laser or any surgical intervention, I give them a one-off stat dose. But also if they go to see the dentist or have any other surgical intervention, it's good knowledge to know that the vascular network and guidelines suggest that they should have a stat dose of an antibiotic.
Thank you so much, Vikas. It's been an absolute pleasure to have you talk about HHT. We've obviously covered a huge amount within this topic, from the genetic components in multidisciplinary fashion, all the way through to the conservative medical and, of course, surgical ladder steps when it comes to trialing different treatments to best suit these patients. Do you have any closing remarks?
I would just say that, any colleagues who are doing the FRCS Section 2 Viva, it's always nice to be able to quote some references. Now, we have the VASCA network, which is the European network for these kind of conditions, the atypical uncommon diseases. And Claire Chauvelin is a professor at Hammersmith Hospital in Imperial. She's the national lead for HHT and has also been the chair of the VASCA European network for all of these conditions. So if you talk about tranexamic acid or the benefit of surgical intervention, benefit of iron supplementation and hemoglobin, you can just mention Chauvelin et al. It's a really good buyout clause for you to use in this condition. And if you drop that, it increases your chance of getting an 8. So that's my high recommendation for HHT.
Brilliant. That's absolutely wonderful. So thank you so much, Vikas, for joining us on the AOT Pod. Thank you to our listeners for tuning in. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website, aotent.org, and our YouTube channel, AOT ENT Education. Thank you, and see you next time.